The fluorescent lights buzzed like angry insects above Dr. Ethan Cole's head as he stood frozen in the emergency department hallway, his fingers tapping rhythmically against his thigh. 1, 2, 3, 4. 1, 2, 3, 4. The pattern kept him grounded when the world became too loud, too bright, too much. And right now, everything was too much. He could hear the hydraulic hiss of the automatic doors, the beeping of 7 different monitors, the squeak of rubber soles on linoleum, and beneath it all, the elevated heart rate of the teenager on the gurney being rushed past him. 16 years old, female, pale, sweating. But it was her eyes that caught his attention. Dilated pupils, unfocused, tracking movements that weren't there. The attending physician, Dr. Marcus Webb, was barking orders about sepsis protocol, but Ethan's mind was already racing through differential diagnoses that didn't fit the standard presentation. He took a step forward, his mouth opening to speak, when a hand clamped down on his shoulder. Head nurse Patricia Brennan stood beside him, her grip firm, her expression carved from ice. She had been the department's head nurse for 17 years, and in her universe, hierarchy was gospel and protocol was law. Ethan was neither. He was the strange young doctor who counted ceiling tiles, who couldn't make eye contact during morning briefings, who asked questions that made administrators uncomfortable. Patricia leaned close enough that he could smell her coffee breath. "Dr. Cole, this is Dr. Webb's case. You're on the cardiology consult list today, not emergency medicine. Stay in your lane." Her words were clipped, precise, designed to cut. Ethan's hand continued its tapping pattern, faster now. 1, 2, 3, 4, 1, 2, 3, 4. He wanted to explain that staying in lanes was how people died, that medicine wasn't about territorial boundaries, but about seeing what others missed. But the words tangled in his throat like fishing line. Instead, he watched as the teenager, Sarah Brennan, according to the chart he'd glimpsed Patricia's own daughter, disappeared behind the trauma bay curtains. Dr. Webb's voice echoed, "Start broad-spectrum antibiotics. Get blood cultures, lumbar puncture if she deteriorates. Standard sepsis protocol. Safe, reasonable, completely wrong." Ethan could feel it in the way his neurons fired, in the pattern recognition that had made him both brilliant and unbearable to his colleagues. Sarah's symptoms weren't tracking with sepsis. The hallucinations, the specific way her fingers had been flexing, the subtle asymmetry in her facial expression, these were puzzle pieces that formed a different picture entirely, one that antibiotics wouldn't touch. But Patricia was already steering him away, her voice dropping to a venomous whisper. "I've been watching you, Dr. Cole. The way you hover over other doctors' patients, the way you can't follow simple instructions, the way you make everyone uncomfortable with your staring and your mumbling." She released his shoulder with a slight push. "I'm writing this up. You're going to administration. Maybe a formal reprimand will teach you about professional boundaries." Ethan's world tilted slightly, the way it always did when social dynamics became weapons. He understood anatomy, physiology, the elegant logic of biochemical pathways, but he would never understand why saving lives was less important than following unwritten rules about whose patient was whose. The administration office smelled like old paper and disappointment. Ethan sat in the chair across from Dr. Helen Vasquez, the hospital's chief medical officer, while Patricia Brennan stood beside the desk like a prosecuting attorney presenting evidence of his inadequacy. His fingers tapped against his knee beneath the table. 1, 2, 3, 4. But he tried to keep his face neutral, tried to make the eye contact that everyone said was so important, even though it felt like staring into headlights. Dr. Vasquez was reading from a tablet, her expression carefully professional. "Dr. Cole, this is the 3rd incident report this month. Head nurse Brennan has documented multiple instances of you overstepping boundaries with patients under other physicians' care." Patricia's voice cut through the room like a scalpel. "He has no respect for protocol. This morning, he attempted to interfere with Dr. Webb's treatment of a critical patient. He was physically restrained from entering the trauma bay." That wasn't true. Ethan's hands stilled momentarily. He hadn't been physically restrained. He'd been verbally warned and had complied immediately. But correcting her would sound defensive, would make him seem argumentative, would add another checkmark to the list of reasons he didn't fit. Dr. Vasquez looked up, her eyes finding his for a moment before he had to look away, focusing instead on the medical degree hanging on the wall behind her. Johns Hopkins, class of 1998. He catalogued the information automatically, uselessly. Dr. Cole, what's your perspective on this morning's incident? The question hung in the air while Ethan's mind sorted through possible responses, weighing each word for social landmines. The patient, he began, his voice flat, monotone in the way that made people think he didn't care when he cared too much. Sarah Brennan, 16 years old, presenting with altered mental status, fever, hallucinations. Dr. Webb diagnosed sepsis and initiated standard protocol. He paused, trying to organize his thoughts into the linear narrative that neurotypical communication required. But the symptom constellation doesn't fit sepsis. The hallucinations are too specific, visual, not confused rambling. Her finger movements suggest coriform activity. The facial asymmetry, barely noticeable, indicates possible unilateral neurological involvement. Patricia's laugh was bitter. You examined my daughter. You had no authorization. I observed, Ethan interrupted, immediately regretting the breach of social protocol. From the hallway. I didn't touch her. I didn't interfere. I just saw. Dr. Vasquez held up a hand, silencing Patricia. What are you suggesting, Dr. Cole? This was the moment where he could retreat into safety, agree to stay in his lane, promise to stop making people uncomfortable, or he could do what he'd gone to medical school to do. Sydenham's chorea, secondary to acute rheumatic fever, probably from an untreated streptococcal infection weeks ago. The antibiotics Dr. Webb ordered won't address the autoimmune cascade, already destroying her basal ganglia. She needs high-dose corticosteroids, possibly IVIG, and a cardiology consult to check for concurrent rheumatic heart disease. The room fell silent, except for the hum of the air, conditioning and Ethan's internal counting. Patricia's face had gone white, then red. You're diagnosing my daughter with a disease that hasn't been commonly seen in decades, based on watching her roll by on a gurney? Her voice was shaking now, fury and fear mixing into something volatile. You're not just incompetent, Dr. Cole. You're dangerous. Ethan stood in the hospital parking garage 2 hours later, the concrete structure amplifying every sound into an overwhelming cascade of echoes. Car engines, slamming doors, footsteps. His shift had ended, but he couldn't make himself leave. Somewhere above him, in the pediatric intensive care unit, Sarah Brennan was getting worse. He knew it with the same certainty he knew his own name. Dr. Webb would be following sepsis protocol, pumping her full of antibiotics that would do nothing for the autoimmune storm ravaging her nervous system. Patricia would be at her bedside, watching her daughter deteriorate, blaming the disease while hating the doctor who'd tried to warn them. And he was here, suspended pending a formal investigation, escorted from the building by security like a threat instead of a physician. His phone buzzed. A text from Dr. Vasquez. Sarah Brennan has been transferred to PICU. Condition deteriorating. Seizure activity noted. Dr. Webb maintaining sepsis protocol. Thought you should know. It wasn't an admission that Ethan was right. It wasn't authorization to return. It was just information delivered with the clinical neutrality that doctors use to distance themselves from outcomes they couldn't control. But beneath the professional language, Ethan heard something else. A lifeline, a chance. He looked up at the hospital tower, counting windows. 12 floors, 23 windows per floor, 276 points of light against the darkening sky. Somewhere behind one of those windows, a teenage girl was dying because pride and protocol mattered more than pattern recognition. His hands started tapping again. 1, 2, 3, 4. The decision calculus was simple in medical terms, but impossibly complex in social ones. If he went back, if he violated his suspension, if he pushed past Patricia and hospital security and every boundary that kept the medical hierarchy functioning, he would lose his position, possibly his license. Certainly, the fragile acceptance he'd built over 3 years of trying to fit into a profession that valued conformity almost as much as competence. But if he didn't go back, Sarah would die, and he would have to live with the knowledge that he'd seen the pattern, understood the diagnosis, and chosen his career over her life. Ethan walked back toward the hospital entrance, his gait slightly uneven, his fingers still tapping. The security guard at the desk looked up as he approached. "Dr. Cole, I thought you were... I need to see Dr. Vasquez. It's about the Brennan case. It's urgent." The guard hesitated, hand hovering over the phone. In that pause, Ethan catalogued everything he was about to lose. His research fellowship, his apartment that was finally organized exactly right, the Mexican restaurant 3 blocks from the hospital where the staff had learned not to ask him questions and just brought his usual order. The tiny, fragile sense of belonging he'd constructed in a world that seemed designed for everyone but him. But he also catalogued what Sarah would lose if he stayed silent, her future, her dreams, her life. The guard made a decision. "I'll call up. Wait here." 10 minutes later, Ethan was back in Dr. Vasquez's office, but this time the atmosphere was different. The chief medical officer looked exhausted, older than she had that morning. She gestured to the chair. "Sarah's having continuous seizures, not responding to standard anticonvulsants. The MRI shows inflammation in the basal ganglia, exactly where you predicted." She paused, choosing her next words carefully. "Head nurse Brennan is distraught. Dr. Webb is consulting neurology, but they're treating it as encephalitis of unknown origin. I need you to tell me on the record why you think this is Sydenham's chorea and what we should do about it." The PICU was a symphony of mechanical breathing and electronic monitoring, each machine contributing its own rhythm to the urgent melody of critical care. Ethan stood outside Sarah's room, watching through the glass as Patricia Brennan held her daughter's hand, watching the involuntary movements that twisted Sarah's body in ways that should be impossible. Choreiform movements, dance-like, jerky, purposeless, the hallmark of basal ganglia dysfunction. Behind him, Dr. Vasquez was on the phone with the hospital's legal counsel, explaining why she was about to reinstate a suspended physician and override an attending doctor's treatment plan. The conversation was tense, filled with phrases like liability concerns and unusual circumstances and patient advocacy. But bureaucracy moved slowly, and Sarah was running out of time. The seizures had been controlled temporarily, but the underlying autoimmune process was still active, still destroying neurons, still progressing toward permanent brain damage or death. Ethan could see it in the data streaming across the monitors: heart rate variability, indicating autonomic dysfunction, temperature dysregulation, the subtle EEG, changes that suggested spreading inflammation. Dr. Webb appeared at the end of the hallway, his face stormy. He was a good doctor, Ethan knew. Competent and thorough, but good wasn't always enough. Medicine required more than following algorithms. It required seeing patterns in chaos, connecting dots that seemed unrelated, thinking in differentials that included the rare and the unexpected. "Dr. Cole," Webb's voice was tight with controlled anger. "You're suspended. You shouldn't be here." Before Ethan could respond, Dr. Vasquez ended her call and stepped between them. "Dr. Webb, we need to talk about Sarah Brennan's diagnosis. Dr. Cole has presented a compelling case for Sydenham's chorea secondary to acute rheumatic fever. Given the patient's deterioration under current treatment, I'm authorizing a diagnostic and therapeutic trial of his proposed protocol." Webb's expression hardened. "You're going to let a suspended physician, who couldn't even bother to examine the patient properly, override my clinical judgment based on what? A hunch, a glance from a hallway. Based on clinical reasoning, Dr. Vasquez replied, her voice carrying the weight of administrative authority. Dr. Cole, explain your rationale. All of it, from the beginning. Ethan's fingers tapped against his thigh as he organized the cascade of observations into linear speech. Sarah had a sore throat approximately 6 weeks ago, probably treated it as viral, didn't seek medical attention, or received inadequate antibiotic coverage. Streptococcus pyogenes. The infection resolved, but the antibodies generated against the bacterial M protein cross-reacted with proteins in her basal ganglia. Molecular mimicry. The autoimmune attack began weeks later, manifesting first as subtle personality changes, probably dismissed as teenage moodiness. He was talking faster now, the words coming easier when they were about medicine instead of social navigation. Then came the choriform movements, which family might have interpreted as nervousness or fidgeting. The hallucinations represent advanced involvement. The fever isn't from active infection, it's inflammatory. The asymmetric facial movements suggest involvement of cranial nerve nuclei, and if the autoimmune process has reached the heart, she needs an echocardiogram. Webb interrupted, his anger giving way to clinical concern. Rheumatic heart disease, mitral valve involvement most, and commonly, Ethan nodded. 80% of Sydenham's patients have concurrent carditis. The antibiotics you prescribed won't stop an autoimmune process. She needs immunosuppression, high-dose methylprednisolone, 1 gram IV daily for 3 to 5 days. IVG if she doesn't respond. Plasmapheresis as a last resort. Patricia appeared in the doorway of Sarah's room, her face streaked with tears. "What are you all talking about? What's happening to my daughter?" The conference room had become a war room. On one side of the table sat Dr. Webb and Patricia Brennan, united by their shared skepticism and the professional hierarchy that Ethan had violated. On the other side sat Dr. Vasquez and Ethan, armed with medical literature pulled from databases and the fragile authority of clinical reasoning. Between them lay Sarah's fate, measured in the minutes it would take to make a decision. Patricia's voice shook as she spoke. "You want me to trust the diagnosis of a doctor I reported this morning? A doctor who can't even look me in the eye when he talks? A doctor who everyone knows is different?" The word hung in the air like an accusation. Different. It was the euphemism people used when they didn't want to say autistic, when they didn't want to acknowledge that Ethan's brain processed information in patterns and connections that seemed alien to neurotypical minds. Different meant other. Different meant less reliable. Different meant his clinical genius could be dismissed because he counted ceiling tiles and avoided handshakes. Ethan forced himself to meet Patricia's gaze, holding it for 3 excruciating seconds before his neural pathways screamed for relief, and he looked away. "I understand your hesitation," he said, his voice carefully modulated, each word chosen to minimize the flatness that people mistook for lack of caring. "I violated social protocols this morning. I overstepped boundaries. I made you uncomfortable, but your daughter is dying, and social protocols don't save lives. Pattern recognition does." Dr. Webb leaned forward, his expression thoughtful now rather than hostile. "Walk me through the differential diagnosis. Convince me that this isn't encephalitis, isn't sepsis, isn't any of the more common presentations." This was Ethan's language, not small talk or emotional reassurance or the subtle dance of social hierarchy, but pure clinical reasoning. "Start with the timeline," he began. "Symptoms began approximately 2 weeks ago with behavioral changes, impulsivity, emotional lability, declining school performance. Classic psychiatric prodrome of Sydenham's career, often misdiagnosed as attention deficit disorder or oppositional behavior. Then came the motor symptoms, coriform movements involving the face, tongue, and limbs. The hallucinations are visual and complex, not the confused delirium of encephalitis or sepsis. She's frightened by what she sees, but she knows the visions aren't real. Intact insight despite altered perception." He pulled up an image on the conference room monitor, a flowchart of diagnostic criteria. Jones criteria for acute rheumatic fever. Major criteria include carditis, polyarthritis, chorea, erythema marginatum, and subcutaneous nodules. She has chorea definitively. The echo will likely show carditis. Minor criteria include fever, elevated inflammatory markers, and prolonged PR interval on EKG. She has all 3. Plus evidence of preceding streptococcal infection if we check anti-streptococcal antibody titers, ASO, or anti-DNase B. Patricia was staring at the screen, her medical training from decades ago resurfacing beneath the fear. But Sydenham's chorea is rare. I haven't seen a case in 15 years. Rare doesn't mean impossible, Ethan replied, and the rarity makes it more likely to be missed, not less likely to occur. Cognitive bias toward common diagnoses kills patients. Sepsis is common, so we see sepsis everywhere, even when the pattern doesn't fit. Dr. Vasquez tapped her tablet. The literature supports Dr. Cole's assessment. Sydenham's chorea occurs in 20 to 30% of acute rheumatic fever cases, usually in children and adolescents. Onset is 2 to 6 months after streptococcal infection. Treatment is immunosuppression and prophylactic antibiotics to prevent recurrence. Webb nodded slowly. If you're right, then the antibiotics I ordered are useless except as prophylaxis. The steroids are critical, but if you're wrong, he didn't finish the sentence. They all knew the consequences of giving high-dose steroids to a patient with undiagnosed infection. The echocardiogram probe glided across Sarah's chest as the ultrasound technician searched for her heart's rhythm behind the involuntary movements that made positioning difficult. Ethan stood in the corner of the room, making himself small, trying to be invisible while his mind catalogued every flicker of data on the screen. Patricia sat beside her daughter's bed, one hand gripping Sarah's, the other pressed against her own mouth as if physically holding back the fear that threatened to overwhelm her. Dr. Webb operated the ultrasound controls with the efficiency of thousands of prior examinations, but Ethan could see the tension in his shoulders, the way his jaw clenched when the image came into focus. There on the screen was the confirmation Ethan had predicted. The mitral valve, thickened and irregular, opening and closing with abnormal motion, regurgitation, blood flowing backward through a valve that should be watertight, the beginnings of rheumatic heart disease, an autoimmune attack that could permanently damage Sarah's cardiovascular system if not stopped immediately. Moderate mitral regurgitation, Webb said quietly, his voice stripped of the defensive anger from earlier. Valve leaflets show thickening consistent with active endocarditis, mild left atrial enlargement. He turned to look at Ethan, really look at him, seeing past the awkward social presentation to the clinical mind beneath. You were right, Dr. Cole. This is acute rheumatic fever with both chorea and carditis. Major criteria satisfied. Patricia made a sound halfway between a sob and a gasp. What does that mean? What happens now? Dr. Vasquez stepped forward, her administrator's persona giving way to the physician she'd been before climbing the bureaucratic ladder. It means we start high-dose steroids immediately. Methylprednisolone, 1 gram intravenous daily. We add prophylactic penicillin to prevent future streptococcal infections. We monitor cardiac function closely, and we hope that we caught it in time to prevent permanent damage. She paused, then added with careful emphasis, Dr. Cole's diagnosis was correct. If we'd continued treating for sepsis alone, Sarah would likely have suffered irreversible neurological and cardiac injury or died. The words hung in the air like an indictment. Patricia turned to look at Ethan, her expression complex, gratitude warring with embarrassment, relief battling against the cognitive dissonance of having her prejudices proven catastrophically wrong. You saved her, she whispered. After I reported you, after I called you dangerous, you still saved her. Ethan's fingers tapped against his thigh. 1, 2, 3, 4, a self-soothing rhythm that kept his nervous system regulated when emotions became too intense. He wanted to say that saving her was the only thing that mattered, that holding grudges was illogical, that medicine transcended personal conflicts. But what came out was simpler, flatter, more honest. She's 16. She has a whole life ahead of her. The life is more important than the conflict. Dr. Webb was already ordering the methylprednisolone, setting in motion the cascade of interventions that would hopefully reverse the autoimmune attack before permanent damage occurred. The PICU nurses moved with practiced efficiency, starting IV lines, adjusting monitors, documenting everything in real time. Within 20 minutes, the first dose of steroids was infusing into Sarah's bloodstream, beginning the battle against her own immune system. But Sarah's choriform movements were getting worse, not better. Her body twisted and jerked despite the sedation, her face contorting in expressions that looked like pain, but weren't, involuntary muscle contractions driven by inflamed basal ganglia. The seizures had been controlled, but the underlying neurological storm continued, each spasm potentially causing more damage, more cell death, more permanent loss of function. 48 hours into high-dose steroid therapy, Sarah was still deteriorating. Ethan had been officially reinstated, his suspension lifted with administrative apologies that felt hollow against the backdrop of a teenager fighting for her neurological future. He'd barely left the hospital, catching 3-hour sleep intervals in the on-call room, eating protein bars from vending machines, existing in the liminal space between exhaustion and hyperfocus that made the world both sharper and more distant. The PICU had become his universe, a controlled environment where medical data flowed in predictable patterns and social interactions were minimized to essential clinical communication. But even here, even in his element, doubt crept in. The steroids should have worked by now. The inflammatory markers should be trending downward. The coriform movements should be decreasing. Instead, Sarah's symptoms had plateaued at a catastrophic level, her body a battleground where immune cells attacked neural tissue despite pharmaceutical intervention. Dr. Vasquez found him at 3 a.m., standing outside Sarah's room and staring at the trend data on the computer screen. "You haven't gone home," she observed, her voice carrying neither judgment nor surprise. "The treatment isn't working fast enough," Ethan replied, his eyes tracking Sarah's vital signs on the monitor. "The methylprednisolone should have shown measurable improvement by now. Either the autoimmune process is too advanced or we're missing something." "What could we be missing? The diagnosis is confirmed. The treatment is evidence-based. Sometimes medicine just takes time." But time was something Sarah didn't have. Ethan could see it in the subtle changes that others missed. The way her EEG patterns were showing increasing disorganization, the progressive elevation of her cardiac enzymes suggesting ongoing myocardial inflammation, the blood pressure variability indicating autonomic dysfunction. "We need to escalate," he said, his voice taking on the edge of certainty that made people uncomfortable because it came without social softening, without the cushioning phrases that made difficult truths easier to swallow. EVIG, intravenous immunoglobulin, 2 grams per kilogram over 2 to 5 days. It's used in severe cases of Sydenham's chorea when steroids alone are insufficient. Dr. Vasquez pulled up the literature on her tablet, scanning abstracts in the dim hallway light. "The evidence is limited. Case reports, small case series. No randomized controlled trials. Insurance will fight the coverage. IVIG is expensive. Over $10,000 per treatment course. And Sarah's life is priceless," Ethan countered, then immediately recognized the social misstep, the implication that Dr. Vasquez cared more about money than patients. He tried to correct course. "I know the financial constraints are real. I know we can't make decisions based on individual emotional appeals without considering systematic resource allocation, but the clinical trajectory suggests she won't survive without escalation. The risk-benefit ratio favors IVG." Patricia appeared at the end of the hallway, moving toward them with the exhausted determination of a mother who hadn't slept in days. She'd been transformed by the crisis, the rigid hierarchy and protocol-obsessed head nurse replaced by something more fundamental, more human. "I heard you mention IVG," she said, her voice hoarse. "I've been researching, reading everything I can find about Sydenham's chorea. Some patients don't respond to steroids alone. They need additional immunosuppression." She looked directly at Ethan, holding his gaze in a way that would normally make him look away. But this time, he forced himself to maintain eye contact, to push through the neural discomfort, because this moment required it. Dr. Cole, if you think Sarah needs IVIG, then she needs IVIG. I trust your clinical judgment. After everything, I trust you. The Pharmacy Review Board met at 8 a.m. to discuss Sarah's case. A collection of administrators, pharmacists and physicians gathered in a conference room that smelled like coffee and bureaucratic caution. Ethan presented the clinical rationale for IVIG, his delivery methodical and data-driven, stripped of emotional appeals because emotions were the language he'd never quite mastered. He showed them the trend lines, the laboratory values, the imaging studies. He walked them through the pathophysiology of molecular mimicry and autoimmune neurological disorders. He cited the limited but compelling literature on IVIG in refractory, Sydenham's Korea. But it was Patricia who closed the argument. She stood at the front of the room, still wearing her head nurse uniform from the night shift she'd refused to miss despite her daughter's hospitalization, and spoke with the authority of 17 years managing hospital resources. I've spent my career enforcing formularies and questioning expensive treatments, she began, her voice steady despite the exhaustion and fear. I've been the person saying no when doctors wanted to try experimental therapies or off-label medications. I've been the gatekeeper, the bureaucrat, the one who makes physicians justify every decision that costs money. And this morning, I'm asking you to approve a $10,000 treatment for my daughter based on the recommendation of a doctor I tried to get fired 2 days ago. The room was silent, except for the hum of the ventilation system. Dr. Cole sees patterns that the rest of us miss. He thinks differently, communicates differently, experiences the world differently. And for years, I've treated that difference as a deficit instead of a strength. I've filed reports about his boundary violations when he was trying to save lives. I've complained about his social awkwardness when I should have been learning from his clinical excellence. I've been wrong about everything. She looked at Ethan, and this time he managed to hold her gaze for 5 full seconds, a personal record. Sarah is dying. Because I dismissed strep throat symptoms 6 weeks ago, because I was too busy managing nursing schedules to take my daughter to urgent care. And she's alive right now, because Dr. Cole saw what everyone else missed, because his autistic brain made connections that our neurotypical algorithms couldn't. So when he tells me she needs IVIG, I believe him. And you should too. The pharmacy director, Dr. Raymond Chen, reviewed the chart on his tablet one more time. The evidence is thin. Off-label use, high cost, significant insurance appeal likely, but the patient is critically ill and deteriorating despite standard therapy. The proposed treatment has biological plausibility and documented success in similar cases. He looked at Ethan. Dr. Cole, if we approve this, you understand that you own the outcome. If she doesn't respond, if she has adverse effects, if this decision is questioned during morbidity and mortality review, your clinical judgment is on the line. Ethan's fingers tapped his familiar rhythm against his thigh. 1, 2, 3, 4. 1, 2, 3, 4. I understand. I accept responsibility. But I also accept that doing nothing guarantees failure. IVIG gives her a chance. That's all we can offer in medicine. Chances, probabilities, interventions that shift odds in our favor. Certainty doesn't exist, but patterns do. And the pattern here says she needs escalation. Dr. Chen nodded slowly. IVIG approved. 2 grams per kilogram. Divided over 5 days. Continue methylprednisolone. Monitor closely for adverse effects, aseptic meningitis, hemolysis, thrombosis. Document everything. And Dr. Cole, I hope your pattern recognition is as good as head nurse Brennan believes it is. The IVIG infused slowly, droplet by droplet, carrying pooled antibodies from thousands of blood donors into Sarah's circulation. The treatment worked through mechanisms that weren't fully understood, possibly blocking the pathological. Antibodies attacking her brain, possibly modulating immune cell function, possibly through effects on complement proteins and inflammatory cytokines. Medicine was like that sometimes, Ethan reflected, using treatments that worked without completely understanding why, trusting empirical evidence over mechanistic clarity. He sat in Sarah's room at hour 16 of the infusion, monitoring for adverse reactions while Patricia dozed in the chair beside her daughter's bed. The choriform, Movements had begun to diminish, subtle at first, barely measurable but present. Sarah's fingers, which had been flexing and extending in constant involuntary patterns, were starting to find moments of stillness. Her facial movements, the grimacing and tongue protrusions that had been constant, were decreasing in frequency. Dr. Webb entered quietly, checking the monitors and examining Sarah with the careful thoroughness that characterized good medicine. "Inflammatory markers are trending down," he said softly, not wanting to wake Patricia. "CRP dropped from 85 to 62 in the last 12 hours. First significant improvement since admission." He paused, then added, "You saved her life, Dr. Cole. I should have listened to you from the beginning. I let my ego and my experience bias me toward common diagnoses. I forgot that rare diseases don't read textbooks and patients don't always present according to protocol." Ethan considered the apology, processing it through his particular neurological framework. Webb wasn't a bad doctor. He was a human doctor, subject to the same cognitive biases and heuristic shortcuts that all human brains employed to manage complexity. The difference was that Ethan's autistic brain didn't shortcut the same way. Where neurotypical physicians saw patterns shaped by frequency and social reinforcement, Ethan saw raw data, unfiltered by assumptions about what was common or rare, likely or unlikely. "The diagnostic error wasn't personal," Ethan said, his voice carrying the flatness that people interpreted as coldness, but was simply his baseline effect. "It was systematic. Medical education trains us to think in terms of common presentations and typical patterns. When you hear hoofbeats, think horses, not zebras. But Sarah was a zebra, and zebras die when everyone assumes they're horses." Webb smiled slightly at the metaphor. "So your autism is actually an advantage in diagnosis. Your brain doesn't filter out the zebras." "My brain doesn't filter much of anything," Ethan replied, aware that he was sharing more than he usually did, crossing social boundaries that he normally kept rigid. "I hear every sound, see every detail, process every piece of data without automatically prioritizing what's supposed to be important. It's exhausting. It makes social interaction difficult because I'm tracking every facial micro-expression, every vocal inflection, every environmental variable simultaneously. But in medicine, it means I see patterns that others miss. I notice the asymmetric facial movement that lasted 2 seconds. I register the specific quality of coriform movements versus intention tremor versus ataxia. I connect the strep throat from 6 weeks ago to the psychiatric symptoms from 2 weeks ago to the neurological crisis today." Sarah stirred, her eyes opening for the first time in hours. The hallucinations had stopped, the terror replaced by confusion as she tried to orient herself to the PICU environment. "Mom?" Her voice was weak, slurred by the neurological inflammation, but present, conscious, aware. Patricia jerked awake, immediately at her daughter's side. "I'm here, baby. I'm right here. You're in the hospital. You've been very sick, but you're getting better now. You're going to be okay." 3 weeks later, Ethan stood in the hospital auditorium, surrounded by more people than his nervous system preferred, listening to Dr. Vasquez present his case at the monthly Morbidity and Mortality Conference. The presentation had been reframed as a clinical success story rather than an investigation into protocol violations, but Ethan could feel the weight of judgment from the assembled physicians. Success didn't erase the fact that he'd violated his suspension, overstepped hierarchical boundaries, and challenged an attending physician's clinical judgment. In the medical world, being right wasn't always enough to overcome being difficult. Sarah sat in the front row with Patricia, both wearing visitor badges, both present as living evidence that pattern recognition sometimes mattered more than protocol. Sarah's choriform movements had resolved completely. Her cardiac function had stabilized with only mild, residual mitral regurgitation, and her personality had returned to baseline. She would need prophylactic penicillin for years to prevent recurrent streptococcal infections. Regular echocardiograms to monitor her heart and possibly long-term psychiatric follow-up for the trauma of her illness. But she would live. She would graduate high school, go to college, have a future that had been nearly stolen by molecular mimicry and diagnostic delay. Dr. Vasquez finished her presentation and opened the floor for questions. Dr. Ramesh Kapoor, the chief of neurology, raised his hand. Dr. Cole's clinical reasoning was exemplary and the outcome was excellent, but he violated his suspension to provide care. He overrode an attending physician's judgment. He disregarded hospital hierarchy. How do we balance clinical excellence against professional conduct? The question hung in the air, and Ethan felt dozens of eyes turning toward him. This was the moment where he was supposed to apologize, to show contrition, to demonstrate that he understood the social contract he'd violated. But Ethan had never been good at performing expected emotions. "I made a choice," he said, his voice flat but clear, carrying to the back of the auditorium. "Follow rules and let a patient die, or break rules and save her life. For me, it wasn't complicated. Medicine exists to reduce suffering and preserve life. Everything else, hierarchy, protocol, professional conduct, those are tools to support that primary mission. When the tools interfere with the mission, the tools need to change, not the mission." Patricia stood, drawing attention to the front row. "I'm the one who reported Dr. Cole. I'm the one who called him dangerous, who questioned his competence, who tried to have him removed from this hospital. And I was wrong, not just about his diagnosis of my daughter, but about what makes a good physician." Her voice strengthened, filling the space with the authority of her years in nursing. "We created a system that values conformity over excellence, that rewards physicians who follow algorithms instead of thinking critically, that punishes the brilliant outliers because they make us uncomfortable. Dr. Cole is autistic. He processes information differently. He communicates differently. He navigates social situations differently. And because of those differences, we nearly killed my daughter by dismissing his clinical judgment." She looked directly at Ethan, and this time the eye contact didn't feel like assault. It felt like connection. "The hospital needs to change. We need to create space for neurodivergent physicians, for doctors who see patterns that neurotypical minds miss, for brilliant clinicians who might not fit the traditional mold of professional behavior. Because the alternative is losing people like Dr. Cole, and the alternative is patients like Sarah dying from preventable diagnostic errors." The auditorium erupted in discussion, voices overlapping in agreement and disagreement. Dr. Vasquez called for order, then announced that the hospital would be forming a committee to review policies around clinical decision-making, physician autonomy, and accommodations for neurodivergent staff. It wasn't a complete victory. Systems changed slowly, and Ethan knew he would always be the difficult doctor, the one who made people uncomfortable. But it was a beginning. Later, as the crowd dispersed, Sarah approached Ethan with her mother beside her. The teenager looked healthy now, her movements controlled, her eyes clear of hallucinations and fear. "Dr. Cole," she said, managing to hold his gaze for a moment before he had to look away. "Thank you for saving my life. Mom told me you got in trouble for helping me, that you risked your career." Ethan's fingers tapped against his thigh. 1, 2, 3, 4. His self-soothing pattern that had become as familiar as breathing. "Your life was worth the risk," he said simply. "Mathematics are straightforward. Potential harm to my career versus loss of your life. The equation solved itself." Sarah smiled, understanding that his flat delivery didn't diminish his sincerity. "Mom says you're autistic, that your brain works differently. I think that's amazing. The world needs more doctors who see things differently, who notice what everyone else misses." Patricia extended her hand, and Ethan forced himself to shake it, despite the sensory discomfort of unexpected touch. "I'm implementing new policies in the emergency department," she said. "All clinical concerns from any physician, regardless of rank or assigned duties, must be formally reviewed. No more dismissing input because someone isn't the primary attending. And I'm working with HR to develop neurodiversity training for all staff." She paused, her voice thick with emotion. "You gave me my daughter back, Dr. Cole. I can never repay that, but I can make sure the hospital system that almost killed her because we didn't listen to you, that system changes. I can make sure no other brilliant physician is silenced, because they're different." Ethan nodded, processing the promise through his particular neurological lens. Change would be slow, resistance would be significant, but Sarah was alive, walking and talking and planning her future. And in the end, that was what medicine was supposed to accomplish. Not perfect adherence to hierarchy, not comfortable conformity to social expectations, but the preservation of life through pattern recognition, clinical reasoning, and the courage to trust what you saw even when everyone else was blind. He walked out of the auditorium into the bright sunshine, counting his steps. 1, 2, 3, 4, and for once, the world didn't feel quite so overwhelming, because sometimes being different wasn't a deficit. Sometimes seeing patterns that others missed wasn't a disorder. Sometimes being autistic wasn't a limitation on clinical excellence. Sometimes it was exactly what saved lives.